So this is what we're going to be doing in this session that I am moderating. And without further ado, again, biographies are in your meeting materials. So I'm going to introduce our first speaker, and then after each speaker speaks and your timer will go off, you're going to come up here to the front, and then we'll have a panel discussion at the end. So please hold your questions for the end of the four presentations. So please join me in welcoming Sean Tunis, who is founder and chief executive officer for the Center for Medical and Technology Policy, who's going to be giving our first presentation.
Good afternoon, and my thanks also to the organizers, the planning committee, for including me. It's an honor and a little intimidating, since I don't really claim to be an expert in either genomic medicine or disparities, but I can promise you that I don't come with a lot of preconceived notions about the topic. I'm going to try to offer a little bit of the payer, public policymaker, public health perspective on this topic, and if nothing else, hopefully it'll be a little bit provocative or thought-provoking. We'll see. Okay, so first of all, policymaker, payer perspective. Obviously, affordability is a huge issue. We haven't talked a lot about it today, but I did want to show you this one slide, which is from the state of Massachusetts. The blue bars are spending in the year of 2001, and the red bars are spending in 2011. You can see that on the far left, overall health spending on publicly funded healthcare programs rose by about $5 billion over that 10-year period. And for every other category of social service spending, the spending level went down over that same 10-year period. So, and that includes public health, mental health, education, housing, human services, et cetera, for a total of a $4 billion reduction in non-health spending. So, whether that's cause and effect, you could have some debates, but it generally aligns with the notion that, if we spend more money on one thing, we don't spend as much money on other things, and, and at least from this data, it suggests that, just to keep in mind that, while payers get beat up a lot about wanting, the kind of the ways in which they push back on additional spending, some of it comes out of this notion that, there isn't, an infinite pool of resources. So again, that's just the data. I'm not, trying to defend any particular response to that, but it's, contextually, I think it's important if we're talking about trying to increase access to services or pay for more services. It's, it's kind of a zero-ish, not quite a zero-sum game, but you get what I'm talking about, hopefully. So, and then just sort of more specific to the workshop topic, workshop topic. It's like a little tongue twister. So the topic is framed as reducing disparities in access to genomic medicine. As I was thinking about it, I kind of wondered if what the real question is, or might be in the minds of payers and health systems, is, are we trying to reduce health disparities through targeted use of genomic medicine? Maybe in your minds those are the same things, but I think from a payer health system point of view, I think they're much less interested in just increasing access to genomic medicine. I think they would be potentially quite interested in how do you reduce, specific disparities in healthcare or health outcomes with the application of genomic medicine. So we can talk later about which of those actually is the intended topic, but I can say with reasonable confidence that the conversation and potential partnerships with payers and health systems will be a whole lot smoother if it's framed, the second way and not the first way. So what are payers thinking? A lot of people wonder that. So what are they thinking? Well, they think about a lot of things, but I'm just going to talk briefly about sort of three kind of areas, or these may be more referred to the kinds of mechanisms and tools that payers have available to them to potentially address disparities or increased access to services. So there's coverage decisions, decisions about paying for individual items and services. Then, of course, there's the whole value-based payment evolution of healthcare spending, which I think could actually potentially be quite relevant to the topic of the workshop. And I'm going to talk a little bit about sort of the population health perspective, and so we'll get into each of these for a few minutes. How did I get down to 7 minutes already? I just did my introduction. Okay, well, the rest of the slides I'm not going to explain, I'll just show them. Okay. So coverage is just about medical necessity. This is just the one-off, are we going to pay for this thing or that thing? In the case of diagnostic tests, Medicare's, guidelines are, is the evidence adequate to determine that the test is more accurate than existing technologies? And if the test changes accuracy, is the evidence adequate to determine how that improves health outcomes? So it all boils down to, you need some kind of scientific evidence that patient outcomes are improved as a result of using any particular item or service, in this case, diagnostic tests. I'm not going to spend much time on this because I could spend time on it, but it's just not a particularly useful tool, in my view, for addressing disparities. I mean, I think if in fact there are some important services, particularly like somebody this morning talked about surgical care that would be indicated by the results of genetic screening tests that are not covered, in that case, this would be a mechanism of trying to show, this would be a mechanism by which you could get payers to potentially cover that service by showing that the health outcomes are improved. But again, I'm not going to spend a lot of time on this. Value-based payment, which in my view is a little bit of a euphemism for shifting financial risk to providers. That's, it sounds better to call it value-based payment, but ultimately it's about, look, the payers want to move from a fee-for-service kind of, a system where, they're responsible for making decisions about what treatments to approve, to, kind of shifting that responsibility to providers, say, hey, if this kind of testing or these services are going to get you better outcomes at lower costs, or, same outcomes at approximately similar costs, that's on you. We're going to try to set up the payment mechanism so the payers get out of the role of making those individual decisions about what is and isn't medically necessary. So this is just very quickly, I could give a long and not very interesting talk on this slide, so I'm not going to do that, but the evolution of healthcare payment models from fee-for-service, pay-for-performance, shared savings, up to bundled payment, capitation, and now alternative payment models, which are sort of various forms of, fixed payment for a package of services, on steroids. But all this amounts to really, if you look at the top bar, is, low provider risk to higher provider risk. This is trying to set up financial mechanisms, again, where as I said, the payers are less responsible for making individual decisions about what is and isn't paid for. Okay, and this just shows that these, if you look at the alternative, the yellow bar, circle, these alternative payment models with more bundling, more capitation, growing very rapidly as a result of the macro legislation that was passed in 2016. That's in Medicare, but happening a lot in all the commercial payers as well as Medicaid. That's so, as you're thinking about the issues of, disparities in access to genomic services, I actually think there's a lot of potentially interesting thinking you could do about what sorts of demonstrations and pilots could be done through the Center for Medicare and Medicaid Innovation, which are, looking at different payment models as ways to improve quality and cost of care. And it's not my impression that a whole lot of dialogue has gone along into discussions with CMMI about disparities in care, but there's certainly a lot of potential for having outcome measures, quality measures, et cetera, that relate to disparities that could be built into these pilots. I just don't think that's been a major focus to date, but it certainly could be. And then the last thing, which is sort of where I would really put the most emphasis in terms of going forward around engaging payers and health systems and providers around, disparities in access to genomic medicines, the sort of population health. So, as many of you probably know, the Agency for Healthcare Research and Quality puts out a yearly National Healthcare Quality and Disparities Report. The last one that's available is September 2016. I'm not sure if they're continuing this and we missed a year or what. It wouldn't shock me if it was discontinued, but this is the latest one there is. Does anyone know? Has it been discontinued? a lot of cool stuff ARC has been doing has been discontinued. But anyway, the point is, there is a report that where, they look at the, 8 conditions that are the leading causes of mortality and morbidity in the U.S. These, this is the list of the 8 conditions. And then for each of the 8 conditions, they present a whole lot of data about where there are important disparities. So this is adult admissions with congestive heart failure by income, as you could expect without looking at the key. Basically, if you're lower income, you have higher admissions for heart failure. These are not mysterious graphs. They don't even need to be labeled. You kind of know, what's what. But that's a disparity by income. This is age-adjusted breast cancer death by race and ethnicity. And if you look on the left, the green triangles are, African-American Black patients have much higher breast cancer deaths. So that's another, area where disparities are well documented. And this is dialysis patients receiving transplant by race. And again, the highest rates of transplants in the Asian population, amongst the lowest would be African Americans, American Indians, et cetera. The only reason I point this out is there is a lot of data out there that says, okay, here's where the health disparities are, for major causes of morbidity and mortality are highly, they've been well documented. And so here's what I think my, recommendation, if you will, about how to address the problem, we're talking about at this workshop is, if you want to increase the level of interest from payers and providers in promoting access to genomic medicine, focus on major public health priorities like that list of 8. Look for empirical evidence of disparities in care, which, as you saw, there are. Identify in what ways genomic medicine could help, for those disparities, and then link or create quality value-based payment initiatives that might help address those, and then generate some evidence to demonstrate, that outcomes and value might be better. So the point is, instead of starting with the idea of let's have broader access to genomic medicine, let's start with the idea of where are the problems with disparities, and then how can genomic medicine potentially help to address those? So that's it for me. Thanks very much.